This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal Child's Nervous System, published in 2026. It's a case report titled Therapies of Last Resort in Pediatric Super-Refractory Status Epilepticus, a case report on combined selective amygdalohippocampectomy, vagus nerve stimulation, and anterior corpus callosotomy.
This is a heavy-hitting topic, Alara. We're talking about super-refractory status epilepticus, or SRSE. For the residents listening, let's define our terms. Status epilepticus becomes refractory when it persists despite first and second-line agents. But SRSE, that's the nightmare scenario, where seizures continue or recur 24 hours or more after the initiation of anesthetic treatment.
Exactly, Dr. Aris. The paper notes the annual incidence is low, about 1.2 to 3 per 100,000, but the stakes are incredibly high. In the pediatric population, the mortality rate for SRSE is 30 to 50%. If the seizure duration is prolonged, that mortality can even reach 60%.
And we often see this in patients with pre-existing drug-resistant epilepsy, which the paper notes affects about 30% of individuals with epilepsy. The case described here involves an 8-year-old girl who really represents the complexity of this condition.
Right. This patient had a significant medical history: spastic quadriplegic cerebral palsy, drug-resistant epilepsy, cortical visual impairment, and bilateral hearing loss. She was PEG-fed due to dysphagia. Her chronic anti-seizure therapy already included clobazam, sodium valproate, and vigabatrin.
What triggered the acute episode in this case?
It's interesting. She had undergone an adenine tonsillectomy 1 month prior. After that, her parents saw a sharp decline in seizure control. When she arrived at the neurosurgery unit, she was critically ill and cachectic, with a BMI of only 12.2. Clinically, she was exhibiting myoclonus, forced left gaze deviation, and hypersalivation.
The authors describe her as being in a super-refractory state because the referring ICU had already tried benzodiazepines, dexamethasone, and multiple anti-seizure medications, all without success. When you're at that point, where medical management has failed, the clock is ticking on neuronal necrosis and network reorganization.
This is where the paper gets into the surgical decision-making. Usually, emergency epilepsy surgery is the last resort because there's limited evidence compared to chronic cases. But here, they moved forward with a sequential multimodal approach. The first step was a left selective amygdalohippocampectomy, or SAH.
Let's pause there for the residents. Why a selective amygdalohippocampectomy in an acute SRSE setting?
The authors highlight that SAH targets the epileptogenic mesial temporal structures while specifically preserving the surrounding neocortex and the critical neurovascular anatomy. They used an epilepsy-specific 3T MRI protocol to facilitate the localization of that epileptogenic zone. In this patient, once the SAH was performed, they observed immediate seizure cessation.
That's a powerful result in an acute setting. But the study doesn't stop there. As we know with these complex structural cases, recurrence is a major risk, approaching 20% in patients with underlying structural or metabolic disorders. In this case, they had to escalate to neuromodulation and disconnection.
Correct. Following recurrent episodes, the team implemented 2 more procedures: vagus nerve stimulation, or VNS, and an anterior corpus callosotomy. It's the combination of all 3, resective, neuromodulatory, and disconnection, in a single patient that makes this report so rare.
It's an aggressive strategy, but let's look at the why. The goal in SRSE isn't just seizure control in the long term, it's stopping the immediate exotoxic injury. The authors argue that early neurosurgical intervention can arrest ongoing activity and limit that cascade of cerebral damage, the necrosis and gliosis you mentioned earlier.
And the outcome for this 8-year-old was quite remarkable. They achieved a sustained reduction in seizure frequency and severity, eventually reaching an Engel Class II outcome.
For those following along, Engel Class II means rare disabling seizures. Considering she started in a state of super-refractory status with a 50% mortality risk, that is a massive clinical win. It allowed for an improved quality of life in a high-risk patient who was otherwise failing maximal pharmacological and anesthetic therapy.
I found the discussion on the timing of surgery very compelling. The authors suggest that we shouldn't wait until the pharmacological options are completely exhausted and the brain is already structurally devastated by the status itself. They advocate for earlier consideration of these surgical strategies.
It shifts the paradigm of last resort. If we wait too long, we're operating on a brain that has already undergone massive network reorganization. By integrating resective surgery like SAH with neuromodulation like VNS and disconnection like the callosotomy, you're attacking the seizure network from 3 different angles.
Exactly. The SAH removes the engine, the callosotomy prevents the spread across hemispheres, and the VNS provides that ongoing neuromodulatory stabilization. It's a comprehensive approach to rebooting the electrical environment of the brain.
Any specific surgical pearls from the paper regarding the procedures themselves?
The authors emphasize that the SAH must be precise. In the pediatric population, especially with patients with cerebral palsy and existing neurodevelopmental delays, you want to be as selective as possible to avoid further morbidity while still being aggressive enough to stop the status.
It's a delicate balance. The paper also mentions that management of SRSE is currently unstandardized and highly individualized. We often see practitioners using ketamine, immunotherapy, or the ketogenic diet as adjunctive strategies. But this case puts surgery front and center as a definitive intervention.
It really does. It contributes to a growing body of evidence that surgery shouldn't just be what we do when we've given up, but rather a targeted tool used to save the brain from the status itself.
A key takeaway for our listeners: SRSE is a neurological emergency where time is neurons. When you have a patient with drug-resistant epilepsy who enters status, don't just keep adding sedatives and anesthetics. Start the multidisciplinary evaluation for surgery early.
And don't be afraid of the multimodal approach. This case shows that combining these techniques, resection, VNS, and callosotomy, can lead to near-complete remission even in the most severe cases.
Well said, Alara. This case report from Child's Nervous System is a great reminder of the evolving role of the functional neurosurgeon in the ICU.
That's all for today's episode. We'll link the study in the show notes for those who want to dive into the EEG and MRI specifics.
I'm Dr. Aris.
And I'm Dr. Alara.
We'll see you next time on the Neurosurgery Hub podcast. Keep learning and keep operating.